on the chest injuries chapter. So this is an interesting chapter because there's some things that present fairly similarly, but they're tested frequently. The small nuances between them, like the difference between a hemothorax and pneumothorax and all that, and tamponade and JVD and all these things we're going to learn about over the next hour or so. And this is a little bit of a different format. I'm using a little bit of a different book, and I'm using the EMT book instead of the advanced EMT book. And so at the end, there will be some questions that we'll review some high yield concepts on. So here we go. And so chest trauma causes more than 1.2 million emergency department visits every year. So unfortunately, when people fall, a lot of times they'll hurt their chest. And so, we could talk real quick, but of course, the heart, lungs, and great blood vessels sit within the chest cavity, the thorax, right? The medical word for the chest is the thorax. This area is the thorax. And so the reason this is surrounded by the ribs is to protect these very, very, very important structures. And so there's a reason that our most important structures, i.e. the brain, heart, lungs, kidneys, are all very, very, the spinal cord, they're all protected by bone. And so that's the reason that it's done that way is because, through evolution or whatever you want to believe, we have evolved to protect ourselves that way. And so, the chest may be the result of, or maybe the result of blunt trauma, penetrating trauma, or both. Obviously, a car wreck could be blunt trauma and penetrating trauma, or assaults could be blunt and penetrating. So there's obviously variances in that. So we're going to immediately treat injuries that interfere with normal breathing function. And so this is the issue, probably the main issue with chest injuries, like a broken rib per se, or a flail segment or something like that. It creates it to where it's very difficult and or painful to breathe. Same with a pneumothorax or hemothorax. These interfere with breathing. And so we a lot of times have to intervene with this pathology and treat them with supported ventilations and stuff like that, or needle decompression or whatever we're going to do for the disorder. And so that's where I'm getting at. We have to commonly intervene on these. And so internal bleeding can compress the lungs and heart. That is a form of, what type of shock is that? When we obstruct something by compression. It's obstructive shock, yes. Air may collect in the chest, preventing lung expansion. Again, obstructive shock, right? If this starts pushing on the heart and great vessels, that is a tension pneumothorax. That's obstructive shock. Okay, we'll talk about what those are. And so, remember, there's a difference between ventilation and respiration and breathing, right? Ventilation is the body's ability to move air in and out of the lungs, or in and out of the chest and the lung tissue. And so, respiration is different. That's at like the cellular level, but just the act of moving air in and out is ventilation. That is why we call it a ventilator. I was going over a paramedic exam recently, and a lot of students got that wrong. And it just shocked me. And I was like, guys, there's a difference between ventilation and breathing. And so do know the difference between that because it shows up on exams. And so oxygenation is the process of delivering oxygen to the blood by diffusion, a little step further, simple diffusion, from the alveoli following inhalation into the lungs. And so that's intuitive. We know we breathe about 21% oxygen in through the atmosphere. It goes into the lungs where it meets with venous blood that is deoxygenated, and so diffusion takes place. The blood, there'll be a movement of high concentration to low concentration of oxygen, and the other way of carbon dioxide from high concentration to low concentration, and then we'll breathe out carbon dioxide. So we know this process by now, but that is a quick recapitulation on that. And so be aware what oxygenation is, and delivering those nutrients to cells is perfusion, right? And so lack of perfusion or hypoperfusion is shock. And so injuries may affect both ventilation or oxygenation. And so there is a difference between those. And, we've covered that in like a VQ mismatch with pulmonary embolism. And so this is talking about chest wall anatomy. And so thoracic skin, muscle, and bones. And so you'll see that this is striated muscle, but what are the, test question, what is the main muscle of breathing? It's the diaphragm. And so the diaphragm is a dome-shaped skeletal muscle. And so when it contracts, when muscles contract, they get smaller. And so when it gets smaller, it goes like this and it sucks air in. And when it relaxes, it pops back up to that dome shape. And so that is the diaphragm. What is the other muscle? That's the main muscle of breathing. What are some of the other muscles that we can use in breathing? The intercostals, right? That is the muscle between the ribs, right? And so there is some striated skeletal muscle between the ribs that aids us in breathing. Okay, and so a quick run through the heart. This is the vena cava to the right atrium. We try before we buy tricuspid valve, right ventricle. Pulmonic artery is going to carry deoxygenated blood out to the lungs, right? Even though it's an artery, it's going the other way. It's right here. And then into the lungs where diffusion will take place. Now, oxygenated blood will come back in through the pulmonic vein. It is oxygenated. That is weird. To the left atrium, to the tricuspid mitral valve, to the left ventricle, and out through the aorta. When we go up to the aorta, you should note the aorta comes out of the left ventricle and it takes a pretty hard turn. This is called the aortic arch. And you can feel the aortic arch right here. If you push down, you might be able to feel a chunk of the aortic arch or some of the vessels. And so just be aware that this will give you your carotids and the subclavian, all right, brachial. And so these are the main vessels that will come off of that arch of the aorta. And the reason I'm covering that is because we're going to talk about what happens when this gets torn. You die very quickly. And so we know that this is the patient's right. And so there's 3 lobes on the right side and there's 2 lobes on the patient's left side. Okay. So there's a lining within the lung cavities. And so remember that we have parietal pleura. And we also have visceral pleura. Whoops. Which one lines the vital organs? It is the visceral, right? So it lines the organ itself. So that's the one that's actually stuck to the lung. And the parietal pleura is the one that's stuck to the wall of the chest. And so in between that is the pleuritic space or the pleural space. Typically, there's a little bit of like lubricant in there. And so this, as your lungs breathe 20 times a minute for the rest of your life, that could create friction if there wasn't any lubricant there. And so there is a condition known as pleurisy where patients will be missing that for whatever reason, and it sounds like when you listen with your stethoscope that it sounds like hands rubbing together, and so that's called a friction rub. And anyways, that's some stuff to know about the pleural lining. Again, we're going to talk about some disorders with this, okay? And so one thing to point out, if we were gonna, okay, so like this is someone's sternum and there's ribs going this way, right? Not drawn to scale. But if we were to take one of these ribs and cut it in half and look at it that way, okay, the ribs look like this, okay? And so this is like a side angle of a rib, right? So if you were to cut me in half this way and look at my rib, right, or take a rib and break it and look at it like this, right, this is what the rib would look like. But within each of these, there's an artery, there's a vein, and there's also a nerve. It's called the neurovascular bundle, and there's one underneath each rib, and they're kind of tucked up underneath the rib. Okay, so as you can imagine, if someone cracks a rib, there's a nerve right there. So it is very painful, very, very painful. Also, you have the risk of bleeding. There is an artery and a vein underneath each rib, and so that's one of the consequences of a broken rib. Okay, the pleura covers each lung and the thoracic cavity, right? This is what I was talking about. There's a small amount of pleural fluid between the parietal, which is the chest wall, and the visceral that lines the vital organs that allows the lungs to move freely. Okay, and so the vital organs, such as the heart, and the lungs, are protected by ribs, and this is why we have ribs here. It's to protect you. Now, something to point out is you can feel your ribs, right? You can feel where they end, and then you can also kind of feel in your back where they end. And so it goes fairly lower, and it goes lower in your back than it does up front. And so that's by design because there's more lung in the backside. So like you can appreciate that on the backside of this diaphragm, there's more lung. So there's lung all the way down here, even though the front of the rib cage ended at about that level. And so when you listen to someone's lungs, you can listen quite a bit lower on their back than what you can than listening up front. And so really, the lower lobe and both sides of the chest or of the chest are not here. This is more the middle. The lower lobe's truly in the back, at the bottom. So you hear people mess that up all the time. They'll just hear and be like, "Oh, they got lower lobe pneumonia." Well, you didn't really listen to the actual lowest part of the lobe, and so I'm not going to fight someone on that, but just be aware of that. Okay. Now, the mediastinum is a space, and so the mediastinum is this space right here. It's like right where the heart sits. And so the heart, great vessels, esophagus, trachea, this is a little space called the mediastinum. And this word becomes important because it shows up a lot, and we don't talk about it enough for what it is. But the mediastinum, just imagine, it's like a little cavity, a little space, and within that space is the heart, great vessels. What are the great vessels? Aorta, vena cava, stuff like that. Brachial, all them, and then the trachea. The trachea is the airway tube that's rigid, that sits in the front. What sits behind the trachea? The esophagus, the food tube. I used to have a Filipino instructor that called it the esophagus, and he was not kidding. They called it the esophagus. So the diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. We'll talk about when this gets perfed, when it gets blown out, like it's a bad deal. That's at the end of this chapter. And so intercostal muscles are the muscles that the diaphragm this is look, we know the diaphragm is the main muscle of breathing, but we can also use intercostal muscles and the diaphragm to contract during inhalation. So again, when we breathe in, inhalation, inhale, right? Our muscles go like this. The diaphragm goes like this. It flattens out, and so it sucks air in. Right? It's just sucking it in. And so when the intercostal muscle and the diaphragm relax, that's exhalation. So I would ask you, student, which one of these is a passive process? Meaning, which one of these take no energy? It's exhalation. It's a passive process. You can go up to a dead person and push on their chest a little bit, and they'll go, ooh, they'll breathe out, right? And so this is something to keep in mind, that exhalation is a passive process. And so the reason I tell that story about the dead people is because it'll happen kind of often. Like you'll call someone, like you get there, it's a hospice patient, or they're dead, right? And we'll be talking to the family, apologizing for their loss, supporting them through their grief, and then the patient will make out a right. It's that last little bit of air coming through their trachea, and the family's like, "Oh my God, they're alive, save them!" And it's like, no, 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 no. And so I've actually had that happen, and so you have to be mindful of that. The exhalation is a passive process. The body should not have to work very hard to breathe when in a resting state. It is work. I hate the word it shouldn't have to work. That's not correct. It shouldn't have to work very hard. It's always working. Now, this is what I'm talking about. You can tell this one is inhalation because the diaphragm is lowering, right? The diaphragm's going whoosh, and it's remember, when muscles contract, whether it's a bicep or a diaphragm, they get smaller. And so on my arm, the muscle's balled up because it got smaller. In my chest, it's flattening out. So that happens almost like a billowing effect. It like sucks air in, creates a very negative pressure. Okay, and so that's pulling air in. Okay, when we breathe out, the diaphragm will pop up back to its dome shape. The reason that happens is the abdominal contents are pushing up on that, and so it pops back up to a dome shape. So patients with spinal injury below C5 can still breathe from the diaphragm. So let's imagine someone is injured at C5. They snap their neck at the C5, right? Motorcycle accident. What do we call that? It's a complete transection. What do we call that? Quadriplegia. Around the L5S1 area, or maybe it's L1. I don't remember. It's paraplegia. Okay, and so that's the old saying: C2, C3, C4, or C2, 3, 4, 5. Keep the diaphragm alive. Yeah, those are the ones you need to keep the diaphragm alive. So patients with spinal injury to above C3 may lose the ability to breathe. Why is that? Because this is the level that the diaphragm is innervated in. And so the diaphragm, the muscle of breathing, does actually require brain signals sent to it constantly. And so while breathing is a thoughtless thing for you consciously, it is not entirely thoughtless. Your brain is still telling your body to breathe, and that's being sent through messages from the brainstem down into the spinal cord, and it exits around C3-4, and it'll go and innervate the diaphragm. So tidal volume is the amount of air that's moved in and out with a single breath. The famous Evian water bottle that I always lecture with. This is a liter for the thousandth time, and we breathe about a 500 milliliter tidal volume in and out with each normal breath. So you're breathing about half of this in and out. And a BVM, that's like 2,000 milliliters. So that's why you just need to give a little bit until you see chest rise and fall. When you do what I call the firefighter grip, and you're like, whoosh, whoosh, with each BVM squeeze, you're causing damage, right? You can cause what's called barotrauma. It's too much air. So anyways, the normal tidal volume is around 500 milliliters. That's what's normal, give or take. Now, minute ventilation is calculated by multiplying the tidal volume by the number of breaths per minute. So, oh my gosh, math time. If we breathe the tidal volume times, okay, so this says tidal volume times the respiratory rate equals minute volume, or minute ventilation. And so we do 500 milliliters times, let's say they're breathing 12 times a minute. That's going to equal what? 500 times 12. I'm no expert, and if my calculations are correct, that's 6,000 milliliters, also known as 6 liters, also known as 6 Evian water bottles. And so that is what how we would figure that out. Pretty easy, right? Like pretty easy math. So again, don't just panic and be like, gosh, I can't figure it out. You can figure it out. Just work your way through it, you know? And then changing either number affects the amount of air moving throughout the system. And so hang with me. Let me do a little different math. Let's say someone's breathing 300 for their tidal volume. So they're not breathing the normal 500, but they're still breathing 12 times a minute. What does that equal? That's 3,600. So 3.6 liters. So you can see how when we change one of these numbers, it can change significantly. But you're like, well, the patient's small, but we still want 6,000 for the minute ventilation. So what if they're still breathing 300, but we increase this to, let's say they breathe, I don't know, let's just do 20 times a minute. That's still a reasonable rate, just a little bit faster. So what's 300 times 20? That's 6,000. So you're back up to, right? These are equal. You're still breathing 6 liters a minute, right? 6,000 milliliters of air is going in and out a minute, but you're changing you're breathing faster, but you're not breathing as deep. And so that's where we use some of these components, like when you start talking about ventilators and stuff like that, to try to get some of these numbers and play around with them. I will not test you on these exact things, but this is a concept that I want you to know. Okay, I'm not going to ask you to calculate this. Now, just like any type of trauma, there's usually, or I would say any type, but there's open and closed chest traumas, right? Closed is by far more common, but a closed chest injury, the skin is not broken. And with this, I don't like the word skin broken because the skin is technically broken here, right? That's a seatbelt mark, by the way. But it's not like truly broken. So a little bit of an abrasion, that's not broken skin. We're talking like into the deeper layers of the skin in the fat. Okay, that's an open chest injury. And so just keep in mind, a seatbelts are a very common cause of chest injury. And so you may have heard the ridiculous statements that seatbelts, I don't wear my seatbelt because I know they can kill you more than they'll help you. That is ridiculous. I have unbuckled very few, if any. I can only think of like 2 or 3, and it's because they burned, dead bodies from car wrecks, right? So it's the people that die in car wrecks are the people that are not restrained. And so that is an important thing to know is please wear your seatbelt, even in the back of the ambulance. And so when we look at this picture, this is the patient's right. What side of the vehicle was she sitting in? She was a passenger, right? And so, whoops, passenger, right? And so we could use that, like that's like almost like a forensic thing of like, oh, she was sitting in the passenger seat. And so sometimes you can use that if they were like lying about where they were sitting for some weird reason. But anyways, you can use that forensically. Or if they're unconscious or you get on scene late and they've already self-extricated or something like that, you can use that, the seatbelt mark thingy. And so closed chest injury can cause significant cardiac and pulmonary contusion. What's a contusion? A contusion is the medical word for a bruise. Good. And so you can get bruising, okay, on your heart and your lungs. And remember, bruising is a hematoma, right? And so this is when blood vessels break underneath the tissue. And so you could imagine getting a baseball bat to the chest. Just like you're going to bruise externally, you could still bruise internally. And so your heart and lungs can actually bruise. And so this creates all sorts of problems because something that we know about cardiac and pulmonary, so heart and lung bruises specifically, is they tend to swell really, really bad. Okay, and it's because they're rich in blood supply. And so this is one of the consequences of giving IV fluids to these patients is you can overwhelm that area with swelling and cause severe shortness of breath. And so cardiac and pulmonary contusions are 1000% a thing that you will probably see. Okay. So if the heart is damaged, it may not be able to refill with blood, or blood may not be pumped with enough force to eject out of the heart. And so that is a common issue, I would say, is that this is like cardiac tamponade essentially, but you can imagine the heart getting bruised, it's not going to work very effectively. Lung tissue bruising can result in exponential loss of surface area for those alveoli. That edema, essentially that bruise takes that territory of the lung out of service, and so you'll end up shunning blood and hopefully some ventilation to other areas. And so this is a consequence again of pulmonary contusion. Rib fractures may cause further damage, and so you can imagine we're from Texas. You've all seen a beef or a pig rib, right? Pork ribs, delicious. Imagine breaking those, right? They're sharp. And so when you break a bone, what's the sound of two bones rubbing together? What's the medical word for that? The sound and sensation. It's called crepitus. Those shards are very sharp. And so as with each breath, this area is still moving, right? With like a broken leg, you can splint the leg and hold the leg still to where we prevent crepitus and further damage. But and what are you going to do? Have the patient quit breathing? And so you can't really do that with breathing. And so you do risk with rib fractures further damage as these bones rub on each other and rub into soft tissue and cause further damage. Now, an open chest injury, an object penetrates the chest wall itself. Knives, bullets, pieces of metal, shrapnel, broken ends of a fractured rib, all of these things can cause an open chest injury. Blast, severe blunt trauma even can open up the chest. And so do not attempt to move or remove the object. When is the only time we can remove an object? If it interferes with cardiac arrest. Not cardiac arrest, if it interferes with cardiac arrest, right? CPR. And so blunt trauma to the chest may cause, so remember ribs, this little breastbone area is called the sternum. That's the medical word for the breastbone, the sternum. There's a little piece down here called the xiphoid process at the very bottom of the breastbone that breaks off, fairly common in CPR. Bruising of the lungs and heart, damage to the aorta. Remember, the aorta is this huge vessel that comes out of the left ventricle with all these branches. And so when you break this puppy, I mean, it's game over. You're dead. Nothing you can do about that. We'll talk about that. But vital organs to be torn from their attachment in the chest cavity, right? And so something I maybe should have covered in head and neck trauma, but I'll cover it now, is there's this thing called internal decapitation. So if I were to decapitate someone, you were to take their head off, right? Like a guillotine. But to get internally decapitated is when your head's still attached, but everything got dissected, right? It got torn off. And so I've seen that in a couple auto pedestrian accidents where they're hit with so much force, their head's still physically attached, but all the inside stuff is not. It got torn. And so the same thing can happen in the chest. You can get hit like so hard, like hitting a brick wall at 100 miles an hour with no seatbelt. You can push these organs into like completely detach them and move them in the wrong area. And so that is obviously very fatal when that happens to your heart or lungs or any of the vessels. And so signs and symptoms of a chest injury. Intuitive. It's going to hurt a lot. The patients will tell you like it hurts a lot. One of the common things you'll hear, it hurts to breathe, right? They'll say my chest hurts, and then so I'll say take a deep breath for me, and they'll stop. They'll be like, oh, it hurts to breathe, or so that's a very common thing with like broken ribs. It hurts to take a deep breath. It hurts to cough. It hurts to laugh because we use all of that. When we use these muscles to help us in that. So when that's injured, and you use it further, it's going to hurt. And so localized pain aggravated with increased with breathing. And so again, breathing, coughing, laughing, talking, all of those, hiccuping, all that's going to hurt. Bruising to the chest wall. I'll show you some pictures. Crepitus with palpitation of the chest. What's crepitus? I just said this. When bones rub together. Okay. Broken bones rub together. Penetrating injury to the chest and dyspnea. What's dyspnea? It's the medical word for shortness of breath. Hemoptysis. What's hemoptysis? It's the medical word for coughing up blood. Okay. Failure or of one or both sides of the chest to expand normally with inspiration. Rapid weak pulse and a low blood pressure. Cyanosis. What's cyanosis? Bluish tint of the skin. So you can get bluish tint of the skin, also known as cyanosis, around the lips and on the fingernails. That's the first places you'll see it. That's called acrocyanosis in babies. Diminished breath sounds on one side. We'll talk about what that means. It means something is very wrong. Low oxygen saturation. So we'll talk about that. Those are general signs and symptoms, but we're going to talk about when the specific ones show up here in a bit. And so chest injury patients often have rapid and shallow respirations, and it hurts to take a deep breath. That is like a hallmark sign of a broken rib or a contused lung or something like that. It hurts to take a deep breath. And so if you want to test this, you just ask the patient to do that. Can you take a deep breath for me? And they're going to be like, I did. And that's like nothing, right? And it's like, no, I want you to take a very deep breath. And they're not going to because it hurts too bad. Okay. Patient may not be moving air. And the reason is when you break a bunch of ribs, it hurts so bad to breathe. What you'll see is the patient breathes more rapid, but they breathe shallow. And remember that whole minute ventilation thing? To still get their 6 liters of air they need, what they'll do is they'll breathe, a tidal volume of 200, but they'll breathe 30 times a minute. So they're taking these really shallow breaths just often. And while you'll still get some minute ventilation, the total number it still causes problems. It's hyperventilation, and so this isn't sustainable. You can blow off too much CO2 and end up with respiratory alkalosis. So there's all these issues that can create with this, but you're going to want to auscultate multiple locations to assess for the adequate breath sounds. And so this is why it's important that we just don't be like, sounds good to me, right? You should really listen at the apexes, the middle, the bases, the axillaries, the back, the posterior, right? You should really listen in a lot of places when you're assessing chest injury, right? Really any patient, but especially chest injury. And this is why we listen to breath sounds on every patient, not just sick patients. It's hard to know what abnormal is if you don't know what normal is. Okay, and so BSI scene safe, of course. Request law enforcement if the scene's involving violence. Retreat for safety. Your safety first. Your safety first. Your safety first. Call for ALS early if needed. And so we look at the MOI, and so the common cause of these we kind of covered. Motor vehicle collisions is probably the single most common, followed by falls, industrial accidents, assault. Again, people get punched or kicked to the ribs or chest. This can cause, obviously, broken ribs. Determine the number of patients. Consider spinal immobilization. So that's something to consider. Just like a car wreck, you usually assume that there's a cervical injury, so we might take spinal precautions. But the same in the majority of chest trauma is what I'm trying to say. You might still consider cervical injury as well, or spinal injury too. So as always, we go in, we do a general impression, we address life threats and hemorrhage, lack of breathing, all those things. That happens immediately in the general impression. Remember, general impression is your across the room assessment. Oh wow, this patient is shooting blood across the room and they're unresponsive, sitting in a pile of feces, right? Like that's I can see that from over here, and that's really bad, right? And so that's your general impression. And so we note the patient's level of consciousness. How do we do that? Right? We use AVPU. But really, let me cover this for a second. How do we specifically do that? Right? Usually we start off with just greeting the patient. Hello, sir. Why'd you call 911 today? How may I help you? Right? If there's no response, you would step up the tone of your voice, get closer. Hello, sir. I guess you're trying to verbally respond to him now. There's no response. You can do a sternum rub, or you can inflict a little bit of pain to see if you get to elicit a response. There's no response from that, then they're presumed unresponsive, right? So that's how we do that when to perform a rapid physical exam. So airway becomes an issue with chest trauma because it hurts to breathe. And so you need to make sure that they're breathing adequately. Watch for that in vignettes. They'll say patient got kicked in the chest by a horse and they're breathing, 40 times a minute and shallow, and their O2 sats are 88%. What do? You use a VVM with 100% oxygen, right? Because they're not breathing adequately. So we're going to look for, consider early cervical spine immobilization or stabilization if appropriate. Are the jugular veins distended? What are jugular veins? These are me if I try to sing Adele in the shower, or some, I don't know, some good country music. I don't know, but these are the veins that'll stick out when someone bears down. And so, but I've showed you a picture of this. We've talked about it, but this becomes important in assessment of what we're going to talk about in this chapter: hemothorax, pneumothorax, pericardial tamponade. We use these whole jugular vein things very often to help diagnose those. Okay. Is the breathing present and adequate, right? So patients, again, can be breathing 12 times a minute, but they throw the word shallow or 12 times a minute in a regular. It's not normal. So don't get sucked into that. Watch out. That happens. They'll be like, patients breathing 16 times a minute in shallow, and students are like, just glance past it, keep reading the vignette. And when they start throwing, like, so you got to pay attention to when they tell you that, okay? Inspect for decap BTLS. Look for equal expansion of the chest wall. So we should see both sides of the chest rise with inspiration and fall with exhalation, okay? And we're going to look for what's called paradoxical movement, okay? And a paradox is like something moving in an opposite direction. And so paradoxical movement is the opposite direction. So what happens with a paradoxical movement, like you might see like one side up and one side down, right? That would be paradoxical. What's more common is you'll see like a flailed chest come in and out, right? And so that would be paradoxical movement. But paradoxical movement is usually one side up, one side down. And so it's almost like a seesaw type thing. And so that's paradoxical movement. And so we would apply occlusive dressings to all penetrating injuries. We'll show you what these look like in class, but chest seals are essentially really big pieces of tape that cover up the chest. And so if you have penetrating trauma, whether it's a gunshot or a stab wound or whatever, we cover that with an occlusive dressing, okay? And we support ventilations. And so this is difficult, right? And so if the patient has, if it hurts to breathe, how willing do you think they're going to be for you to breathe for them? They're usually not, but this is an exam. So if it says the patient's breathing 12 times a minute and very shallow, right, the answer is still to support ventilations with the bag valve mask device, okay? In real life, that would be very difficult to do, but these are exams, so roll with it. That's what we do. Now, reassess these patients frequently because for all of these issues, right, decreasing oxygen sats, more ineffective or more effective ventilatory support, because these are just like any injury, it's dynamic, right? And so you get there, you're like, I got kicked in the chest by a horse. You load them in the ambulance, you're like, I really can't breathe. And then you're 5 minutes down the road and they're having a full-blown pneumothorax, tension pneumothorax. And so there's a lot of vasculature in the chest, and so things can change very, very quickly in there as far as swelling and blood and pressures. And so these patients really do require frequent remonitoring. Circulation. So what I think one of the greatest indicators of capillary refill is of perfusion is capillary refill. And so you would check cap refill centrally and peripherally, but we could also check pulse rate and quality, skin color and temperature, and address life-threatening bleeding immediately using direct pressure and or a bulky dressing if indicated. Remember, in your torso-junctional wounds, you can use wound packing as well. But not in the chest. We don't wound pack the chest or abdomen, ever. And so, transport decisions, this is where you got to determine, where you're going to take them. A lot of times you'll have to take them to a trauma center, but sometimes you'll just take them to the closest hospital if they're serious, and you don't have time to go to a trauma center. They need a doctor now. And so you have to, again, you need to pay attention to these subtle clues of like the patient telling you like, I'm mildly short of breath, and then 5 minutes later, like, hey, I'm really short of breath, and they're having one word dyspnea, meaning they can only get one word out before sucking in some air. Their level of consciousness, you got there and they were talking to you, and now on the way in, they're getting a little more altered, and then a little bit further into the transport, now they're unconscious, right? Look for that. That happens. A sense of impending doom in the patient. We've covered this in this course. When a patient tells you that they're going to die, you should believe it, right? That is a very serious medical condition when someone says, I feel like I'm going to die. You should believe it. And so this is what they call the deadly dozen of chest injuries. So airway obstruction, i.e., a toddler puts a battery in their mouth and gets it stuck in their airway. Okay, that's deadly. Bronchial disruption. So remember, the trachea comes down and it splits at the level of the carina, and then it breaks off into all these bronchioles. Well, if one of these bronchioles gets torn, right? If one of these bronchioles gets torn, then air is going to escape when it comes through the trachea into the bronchiole and into the chest cavity. And so that is, or into the lung and then the chest cavity. And so this is obviously very fatal. And what you'll see with this is subcutaneous emphysema. Remember, that is the Rice Krispie treats underneath the skin where you push it. There's air underneath your skin, so when you push, it'll feel like Rice Krispie treats. Diaphragmatic tear, we're going to cover this. Esophageal injury, we'll talk about all these. Open pneumothorax, tension pneumothorax, massive hemothorax, hemopneumothorax, flail chest, cardiac tamponade, a thoracic aortic dissection. We'll talk about that. Myocardial contusion, pulmonary contusion. So we'll talk about all these, but just like with all our patients, you start with a good history, a good history taking, good interview. And so you would further investigate the mechanism of injury. Oh, they're in a car wreck. How fast were they going? How fast did they stop? Did they go head on with an 18-wheeler? Did they go head on with a Toyota Prius? Right? Were they wearing their seatbelts? Are the airbags deployed? What is the damage to the vehicle? How many passengers were there? Were there any projectiles within the vehicle, like a Stanley Cup or a bowling ball or something like that that smashed someone's head in? These are all things that you would want to assess on scene. And then we identify the signs and symptoms. Remember, signs are things that you can see. Symptoms are things that your patients report. And then pertinent negatives. What's a pertinent negative? A pertinent negative is to say that they're nauseated, but they have not vomited. So it's positive that the fact that they're nauseated, but it's a pertinent negative, meaning it's an important thing that's not happening, right? Pertinent negative is something that's important, but it hasn't happened yet. So it's important to say that, oh, they're nauseated, but they haven't vomited yet, right? And so that's a pertinent negative. So those are all pertinent negatives. They have chest pain, but they do not have shortness of breath. They're positive for the chest pain, but they're negative for the shortness of breath. Those are pertinent negatives. Important negative symptoms and signs to report. And so the basic evaluation should be completed, and we would focus on the MOI, the mechanism of injury. And so for an isolated injury, focus on the patient's complaint, the body region affected, the location, extent of the injury, the anterior and posterior aspects of the chest wall, and changes in respiration. And so, again, these are dynamic patients. They change quickly. And so for significant trauma, so multi-system trauma, likely affecting multiple systems, we call that multi-system trauma. Start with a rapid physical exam, and then we would use DCAP, BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling to determine the nature and extent of the injury. And so we do a vital sign assessment, pulse, respiration, actually count the respirations, blood pressure, skin condition, oxygen sats, pupils, GCS, blood glucose level, right? Capnography if available. Reevaluate every 5 minutes or less. Pulse and respiratory rates may decrease in later stages of the chest injury. So I keep telling y'all. And so repeat the primary assessment, reassess the chief complaint, and so again, reevaluate the ABCs: airway, breathing, perfusion, pulse, bleeding. And so this is where you're going to observe the trends. And so this is where it's important to have a little bit of a memory and realize, like, okay, we started this call and the patient's blood pressure is 137/87. And now it's 101 over 55. And then I just checked it again 10 minutes or 5 minutes later, and now it's 80 over 40, right? And so you have to remember these trends of where the patient's going, okay? And so we don't just look at one vital sign in isolation, we look at all of them. So we're like, okay, well, when we started, the patient's blood pressure was 137/87, their pulse was 95, they had a GCS of 15, and they're breathing 20 times a minute. 10 minutes later, it's 80 over 40, their GCS is 6, and they're breathing 40 times a minute. Their oxygen saturation is 75%. It's a crashing patient. The patient's dying. And so we look at trends. Somewhere in between that first number and the last numbers I just gave you, there was some change. And so we're trying to identify that before you reach this crashing and dying stage. So again, we place occlusive dressings over the penetrating trauma to the chest wall. I have an occlusive dressing here, but I don't want to open it because they make a mess. But again, just imagine a really industrial size like piece of tape, very sticky. And so you're going to provide aggressive treatment for shock and rapid transport. Remember, a lot of these things at the EMT level we can't fix. And so they need to go to the hospital and usually get like a chest tube or a needle decompression or both or something like that. Okay. And so this is why, again, we're in the business of taking people to the hospital. So we do not delay our treatment to complete non-life-saving treatments or assessments that don't need to be done on scene. Communicate all relevant information to the hospital staff, right? And so this is where we're going to start jumping into the pathology itself, okay? And so the pathology of there's this thing called a pneumothorax. And so pneumo means air, and this literally means in the thorax. So air in the thorax, so air in the chest, okay? And so this is also commonly called a collapsed lung. But guess what? In exams, they won't call it that. They're going to call it a pneumothorax. That is its government name, right? Pneumothorax. And so what happens is you'll end up with this air in the pleural space. And so remember, the pleural space was supposed to be this. Remember, the visceral pleura is what lines the organ, and the parietal pleura is what's lining the chest wall. And so normally there's just a little bitty space here that's supposed to have a little bit of fluid. Well, what happens is in a pneumothorax, this is the patient's right? In the pneumothorax, what happens is you get a hole in the lung. Okay, this can be from penetrating or blunt trauma. Okay, you could get a broken rib that pokes a hole in the lung, right? That from a fall. That's blunt trauma. This could also be from a gunshot or a stab wound, right? Or an explosion. Okay, barometric pressures, right? So like a blast wave can cause this. This is a hollow organ, right? So there's air in there, so there could be pressure injuries. And so what happens is air will start leaking out. And as it leaks out, you will end up with air accumulating in the pleural space. Remember, this space is supposed to be really tight with just a little bit of lubricant. But what happens is as you breathe in more and more air will leak into this space. And so you can anticipate that this is going to lead to problems, okay? Because the lung is going to collapse. That is a collapsed lung, okay? And so you could imagine your assessment of this patient. When you put your stethoscope here, what are you going to hear? You're going to hear diminished airflow. But when you listen here, it's going to sound normal. And so here, diminished, normal. Diminished or absent, normal. Absent, normal. And so this is why we compare side to side, okay? And so you're going to hear what the words they will use on exams are either diminished or absent lung sounds. Very important. They can use either one of those. It means that there is not as much air moving through that area or none at all. And so this is a pneumothorax. And so you would hear either diminished, absent, or abnormal breath sounds. Okay, and so here's what this looks like. And so that is a pneumothorax. And you'd ask yourself, like, wow, that seems really bad. Well, it is. And so paramedics only, this is not EMTs, can stick either their finger or a needle right about here in the chest and drain the air out. Well, it would be the other side. Right here, and they can drain the air out. And so that you can allow the lung to re-expand. So that is a treatment. It's called a needle decompression. As a physician, you can stick a tube in here. And so you can insert a chest tube. Okay. And so an open chest wound, often called an open pneumothorax or a sucking chest wound, is a little different. And so let me just show you this. Same thing. We have a collapse. We have a hole in the lung and a hole in the chest. Okay. And so what happens is you're breathing air in and out. There's a negative pressure inside this cavity, right? Because that's what the diaphragm does. It creates negative pressure. So it's sucking air in, but then it'll also suck air out. And so, there's a rule that says if this hole is 1/3 the size of the trachea or bigger, then you're going to end up with a sucking chest wound. And so what happens is air will follow the path of least resistance. And so again, if it's least resistance for air to go in and out of this hole in the chest instead of air in and out of the trachea, that's what it will do. And so every time the patient takes a breath in and it creates that negative pressure, it sucks. So it's like a sucking chest wound. And so when they breathe out, air and blood will bubble out. And they breathe in, it sucks in. And so this is called an open pneumothorax. And this is particularly bad. But what you can do, one of the immediate treatments, is you just slap a chest seal on that. So you take a chest seal, right, and you slap it on there, and you close it on all sides for now, and you will close that off, okay? And so the wound must be rapidly sealed, an open chest wound with an occlusive dressing, okay? A big piece of tape. And so a flutter valve is a one-way valve, and so we're going to talk about what that is. And so the ones I'm describing have these built in, like a high-fin chest seal, it's built in. And so they're built in a way, and this will make more sense in class when I show you one, but they look like this. Let me just draw it for you. So this is a big band, a piece of tape, and there's a little hole. It's not a hole, but and so this is all one piece of tape, right? But where I'm about to draw to highlight in this blue area right here, these areas don't have adhesive, okay? And so when you slap this over the patient's chest, this will allow air to escape, but it won't come back in, okay? And so creates, in essence, a one-way valve. Air can escape out, but when they suck, right, when the diaphragm flattens and they inhale, air will not go back in. And so this prevents a sucking chest wound, but it also allows air to ventilate and escape, okay? And so let's go back to the drawing board. I have a shot here in my chest, right? And so I have a sucking chest wound. What you would do if you were to truly put something and it's sealed on all sides, not a commercial chest seal, but you could even take like a piece of plastic, right? Like a bag of chips, empty out the chips, right? A piece of plastic and like a sandwich bag and put this over there and you tape it really tight on all the sides, right? You would stop the second chest wound. You could imagine that, right? But what's going to happen is the patient breathes, they're going to end up with a pneumothorax, right? This air will build up in the cavity. And so what happens sometimes is you might have to burp that. And so you would have to untape a side, allow air to escape, and tape it back. That's called burping a chest wound. That's one method if you don't have a commercial chest seal. The other method is you do this. You apply a chest seal and you tape it here, 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 but you don't tape it on the bottom. And again, what this will do is it'll allow air to escape out, but when they breathe in, this valve, that piece of plastic will flap down to where they can't suck as much air in. So again, it creates a one-way valve. And so there's several ways you can do this. We'll show you this in class, and it'll make more sense when I show you. We have a simulator for this to show this to you, but this is an open chest wound. So let me give you the classical vignette. 22-year-old male, stabbed in the right upper chest outside of a bar. He has a sucking chest wound. What's your immediate treatment? You're going to cover the chest wound with a chest seal. Okay, so maybe they tell you that. You've covered his wound with a chest seal. The patient starts decompensating, and now their blood pressure is 80/40, their pulse is 130, their sats are 82%, they're breathing 30 times a minute. What do? You would relieve pressure within that chest seal to allow air to ventilate, and then you would reseal it. Or another option would be to create a one-way valve. Okay? And so there's several ways that this can happen. I hope that makes sense. It'll make more sense when we show you this in person. That's an open chest wound. Now, simple pneumothorax, this is when the lung itself does collapse, but it doesn't create a tension pneumothorax immediately. And so these are fairly common from broken ribs to where you'll get a simple pneumothorax. Simple means it hasn't converted itself to an open or tension pneumothorax. It's just a collapsed lung for now. Now, it sounds stupid for me to say, oh, it's just a collapsed lung, but it's just a collapsed lung for now. And so, interestingly, these can sometimes stay where they're at to where maybe they just have a 10% pneumothorax, right? Just a little bitty pneumothorax, or it can progress into a tension pneumothorax and develop those complications. So This is why we have to monitor those patients. And so uh, this is a very common presentation, is a simple pneumothorax. So how will this present? Depending on the size, they may still have absent lung sounds or diminished lung sounds on the affected side, but they don't have tension pneumothorax symptoms of like hypotension, tachycardia, low sats, tachypnea, right? Altered mental status, decreased level of consciousness. Those are all tension pneumothoraxes, i.e. the next slide, that you have to worry about. So all pneumothoraxes that are closed start simple. Okay, they all start as a simple pneumothorax, but they all have the potential to progress to a tension pneumothorax, depending on the severity and the trauma. And so a tension pneumothorax is, let me just draw this for you. This is when, again, you have a hole in the lung and air is escaping into this cavity, and pressure will build up so much within this cavity. Because remember, with each breath, air is coming into this cavity, and it will build up so much, it will start pushing the lung and collapsing it onto itself and onto the great vessels. And so as air comes in, it's going to start pushing and pushing and pushing and pushing and pushing onto the lung to where it collapses. It really gets really, really small and collapses. And it can push so hard, it will create tension that starts pushing on the great vessels, namely the vena cava. You see this guy right here, that blue guy, this one, right? That's the vena cava. And when the big O vein that's really kind of soft and squishy gets pushed on, it creates decreased preload, meaning there's decreased amount of blood going to the right side of the heart. So that is a tension pneumothorax. And what type of shock is this? It's obstructive shock. It is obstructing the blood from getting up from your belly and your toes into the heart to be pumped. So you end up with a decreased preload. And so this equals obstructive shock. Wow, my handwriting's bad. And so that is a very, very serious medical condition. And so the patient will go into shock. And you would ask yourself, well, and let me say a little further before I talk about that. This can also compress the heart. And so this pressure can build up so much it'll push on the vena cava and aorta, and it can also start pushing on the heart itself. So imagine the heart just trying to do its contraction thingy 100 times a minute, but now it's getting pushed on. It has this tight pressure on it to where it's only able to beat like this. It's obstructed, right? That's obstructive shock. And so that is a tension pneumothorax. And so they even demonstrated this here. Let's imagine this patient they got shot, right? And so there's a hole here, and we taped it on all sides. Well, when you notice patient, was okay, you taped it up, right? They had a second chest wound, you tape it up, right? Went from an open chest wound to a closed chest wound, and now it's progressing to a tension pneumothorax because you're going to notice the patient's going to be agitated, irritated, decreased level of consciousness, altered mental status, right? Brain's the most important perfusion thing, so we'll see those symptoms first. And then we're going to see an increased respiratory rate because they're going to feel short of breath. We're going to see a decreased oxygen saturation because they're having impaired ventilation and perfusion. We're going to see an increased heart rate because their cells are starting to starve for oxygen, right? So it's telling the heart, pick up the pace, get rid of the CO2 trash, deliver me some oxygen. So the heart rate's going to pick up. And eventually, you're going to, remember, one of the last findings you'll find is a decreased blood pressure. It's the last finding in shock. It's a late finding. And so that is obstructive shock, okay? And so let's see what they say here, right? Results from a tension pneumothorax is from ongoing air accumulation in the pleural space, increased pressure in the chest. It causes complete collapse of the unaffected. It can cause complete collapse of the unaffected lung, and the mediastinum is pushed into the opposite area. Okay, I think that would be of the affected lung. That's wrong. Of the affected lung. Shout out JBL. Guys, it's the affected lung that gets collapsed. And so, commonly caused by a blunt injury where a fractured rib lacerates a lung or bronchus. And so, these are usually the more severe pneumothoraxes. And so, again, this is why, read what this is saying down here. This is why we monitor these patients. And if it's sealed on all four sides, you might have to occasionally vent and burp this chest seal that you have applied when it's open. Now, let's imagine that this wasn't here. And you're a paramedic, what we do in the same exact area is we stick a needle or your finger into the chest. We cut and we blunt dissect and we stick your finger into a finger thoracotomy, and so you'll allow air to escape that way. Okay. And so those are pneumothorax, tension pneumothorax. You have to know those. So I hope that you can explain those to me in class when on the discussion when I ask you explain a pneumothorax. Explain the difference between a simple pneumothorax and a tension pneumothorax. I'm going to ask you this in the discussions in class. It's coming up. We'll run some scenarios on it too. And so blood collects in the pleural space from bleeding around the rib cage. This is a hemothorax. So let's break down this word. Hemo means blood. So there's blood in the thorax. I'm getting ahead of myself. There's one more thing I need to tell you. Back onto a tension pneumothorax is a very important thing to know. Let me write out these vital signs. What do you see with a tension pneumothorax? What do you see with a tension pneumothorax? So tension pneumo. What are the vital signs we're going to see? Name these off with me. So the blood pressure is going to do what? The heart rate's going to do what? The respiratory rate's going to do what? Their O2 sats are going to do what? Their mental status is going to do what? And JVD, we'll talk about that, does what? So in a tension pneumothorax, remember the patient will be going to obstructive shock. What's going to happen with these? Okay, the blood pressure, late finding, it's going to decrease. The heart rate, it's going to increase. The respiratory rate, it will increase. The O2 sats, they will decrease. The mental status, it will get worse. JVD will increase in a tension pneumothorax. What is JVD? Remember, the jugular veins become distended. So let's think about this. Just think about this intuitively. Okay? All your blood's coming back to your heart through veins, right? And remember, there's an inferior vena cava. There's an inferior vena cava, or this inferior, and there's superior vena cava. And so all the blood from your head, right, and face is coming down through the inferior vena cava. And so what happens is in a tension pneumothorax, when you start squeezing on this vena cava, the blood backs up. And so you can imagine, right, if I were to push here, right, I don't want to do that. I don't want to do that. But if I were to push, the blood in my JVD or in my jugular veins would become distended. And so I can mimic this. I can mimic this for you now in the cost of science. I'm going to make a fool of myself. If I were to bear down, so I'm going to bear down really tight, that pressure is going to push just for a moment onto my vena cava, the big vein that runs through my chest. And watch what happens to my neck. The veins are going to get engorged. They're going to get bigger because the blood is backing up. So if I were to push, right, bearing down, trying to get these to stick out, they're going to stick out. And as they stick out, that is called jugular venous distension. So you see jugular venous distension in tension pneumothorax, okay? And so that is a hallmark thing. This is a very important thing to know that they're going to maybe tell you on an exam. The patient has jugular venous distension, boom, tension pneumothorax, okay? Or cardiac tamponade. But it's not what we're about to talk about, okay? So you'll see jugular venous distension in a tension pneumothorax. Will you see jugular venous distension in a simple pneumothorax? No, you will not. This is only for, these vital signs are only for a tension pneumothorax. When there's tension, when you are pushing on the great vessels in the heart, when the blood backs up into the neck because it can't make its way through because these vessels are being squeezed and pushed on by this collapsed lung and all the pressure, okay? Now, a hemothorax, right, talking about blood here, blood in the thorax, is when blood collects in the pleural space from the bleeding around the rib cage or from the lungs or from a great vessel or all of them. It kind of depends. And so you can imagine, I mean, I used to know the number. I think you can hold about 6 to 8 liters. So you can hold like 6 to 8 Evian water bottles in each lung, okay? And then so what happens is if you were to just completely fill up this cavity from top to bottom. So what happens is, remember, there's the neurovascular bundle behind each rib. And so if you break a bunch of ribs, you're going to bleed. And so if that bleeding doesn't stop, it's going to build up in the pleural space. And so that is called a hemothorax, meaning there's blood in the thorax. And so this is what it looks like. There's actual blood leaking out from the neurovascular bundles behind each rib, from the great vessels. So if you were to nick the inferior vena cava here, right, you're going to bleed into the thorax, or that's not a good example. If you were to nick the lung itself, like the vessels of the lungs, you could end up with a hemothorax. The great vessels to an extent, depending on the level that they're nicked or cut. And so, how would this present? Right? They're going to have, and so this blood will build up so much it can eventually push on and collapse the lung. Okay, and so again, you can imagine if there's bleeding here, it's going to build up and push and push and push. And the interesting thing about fluids is they don't compress, and so you can't compress water, can't compress blood, but you can compress air. And so these these are not forgiving. Okay, and this can also, the thorax can hold a tremendous amount of fluid, i.e., in this case, blood. You can hold almost every last drop of blood in your entire body in one lung filled, right? Like, it's a tremendous amount of blood it can hold, okay? And so this is what happens is it'll push and push and push and push, and it can eventually kind of collapse the lung. But this can cause obstructive shock, right? You can obstruct this eventually. But more than likely, you're going to end up with hemorrhagic shock. Okay? And so you would imagine also when we listen with our stethoscope, here and here and here. Okay, here, absent, normal. Absent or diminished, normal. Absent, 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 normal, right? And so when we listen, you're going to hear the same things that you would expect in a pneumothorax. You might also see less chest rise and fall. So when I've had to stick needles in people's chest as a paramedic, what I do is I put my hands on their chest, and while they're breathing or we're ventilating them, I make sure that both my hands are rising equally, because I'm not just using my eyes at that point. I'm feeling to make sure that the chest is rising equally. So when you have a pneumothorax or a hemothorax or a hemopneumothorax, you might see unequal chest rise and fall, meaning only this side is coming up and down with ventilations. Okay? Because only this lung is expanding with ventilations. And so that's a hemothorax. And so let's just work through the vital signs on this real quick, right? Let's do it again. What's the heart rate, respiratory rate, SpO2, mental status, blood pressure, and JVD. So let's work through these. What are they going to be for a hemothorax? Heart rate, the patient's dying. It's going to go up. The cells are screaming for oxygen. They're screaming to get rid of the carbon dioxide. It's going to tell the heart speed it up. So the heart rate will go up. That's a known thing in shock. These types of shock. Respiratory rate will go up, right? Because again, the lungs being collapsed, right? They're in shock. Increased metabolic demand, right? Respiratory rate will go up. SpO2 will drop. Mental status will drop. They're in shock. Blood pressure will drop precipitously, very quickly. They're losing their blood in their chest. JVD will be absent. It is absent in this case. Okay, JVD is absent. And so let's think about this. There isn't an issue with blood getting blocked here in this case. It's not building up here. The blood has already dumped into the chest. So all the blood is not backed up in the veins. It's been lost in the chest cavity. And so you will not see JVD in hemothorax. That is a very clear distinction between the two. You do not see JVD in a straight up hemothorax. Why? They are volume depleted. There is no blood backing up in the veins. The blood has been lost inside the chest cavity. They're dying. Okay? And so what is the treatment for this? It's very similar. You stick a tube right here, a physician sticks a chest tube right here, and we drain the blood, okay, in a tube. It's called a chest tube, literally. And so there is this last condition of the chest that I want you to know called a hemopneumothorax. So let's use our phonics and let's figure this out. So this means there's blood and air in the thorax. And so you would ask yourself, well, if a broken rib causes bleeding and it can also puncture the lung, wouldn't this be pretty common? It is very common. It's more common for someone to have a hemopneumothorax than just a straight up hemo or a straight up tension pneumo. Usually they go together, okay? And so as you can imagine, this will present eventually like a tension pneumothorax, with, you know, with the same with the same symptoms. So with a hemopneumo, you'll see an increased heart rate, an increased respiratory rate, decreased SpO2, worsened in mental status, decreased blood pressure. That's a late finding. And JVD can be plus or minus. It depends. Okay, you don't hang your hat on this one for that. Okay, now physical exam will be the same. You'll see unequal chest rise and fall. You'll have shortness of breath. You'll have diminished lung sounds on the affected side. When you listen here, it's going to be diminished, diminished, diminished. There is a test I'll show y'all in class called percussion, where you can percuss the patient's chest like a drum, and it'll make a dull sound because what you're not banging against air like a drum is, you're banging against blood, and so it makes a dull sound of percussion. Okay, that's a hemothorax and a hemopneumothorax. Hemopneumothorax is fairly common. Like I said, they happen, but it's pretty rare to find like a hemothorax in isolation or a tension pneumothorax in strict isolation. Usually there's some blood in there as well, but it can happen. And so shock with signs and symptoms of a hemothorax or shock without any obvious external bleeding or apparent reason for shock. These patients will be real shocky. Diaphoretic, that's the medical word for sweating. Short of breath, anxious, impending doom, feeling like they're going to die. This is bad. You're not only you're losing a tremendous amount of blood that we can't stop. The only person that can stop this is a trauma surgeon or a surgeon. Okay. Decreased breath sounds on the affected sound. Remember, what words could they use? Decreased breath sounds, diminished breath sounds, absent breath sounds, irregular breath sounds. They could use all those words that are telling you, yo, there's something wrong with that side of the chest. Look into it. The treatment's rapid transport, okay? And remember, pneumothorax is when there's the presence of blood and air in the pleural space. Now, that's the lungs. Let's move on to the chest, the heart. There's this thing that I've alluded to called cardiac tamponade. Not tamponade. It's not lemonade we're selling here. It's cardiac tamponade, okay? That is the only way this is pronounced, cardiac tamponade. And so what happens is, this is a great picture. We've talked about this before. There's a thick fibrous heart, or there's a thick fibrous sac that surrounds the heart. It's called the pericardium sac, or the pericardium. Okay, and so just like the lungs, right? There's a parietal, right, which is on the outside, and there's a visceral pericardium, and inside the middle, normally there's supposed to be a little bit of lubrication. So when your heart beats 100 times a minute for the rest of your life, it's lubricated. And so if you lose this lubrication, it causes a condition known as pericarditis. And so what pericardial tamponade is usually you'll get like a blunt trauma, or it can even be penetrating trauma that will cause bleeding from the heart. And so imagine here, you have blood leaking from here. Let's just say it got hit really hard with a baseball. And so now you're leaking blood, or you straight up have a laceration to the heart, right? Or a rupture of the heart, right? The heart exploded or chewed a hole through itself. That's called Dressler syndrome. And so now you're just leaking something, usually it's blood, into this sac. Well, as fluid builds into this sac, this sac is like leather. It's like a thin leather to where it can only get so big. And so it can only get so big, but there's more blood pumping in here with every beat. And so this will start pushing onto the heart. And so the hallmark of this is you'll hear what's called muffled heart tones. Not that you know what normal heart tones are, I expect you know what normal heart tones are, but they sound muffled. So when you listen with your stethoscope, it sounds like you're listening to them underwater because you're listening to them under blood, right? And so they sound muffled, right? And so that's one of the hallmark things you'll hear. And so the problem with this is this creates, again, obstructive shock. Imagine with me, the heart's having to pump like this, right? And it's a little sac. But when that sac starts pushing on the heart starts beating like this. Is that effective pumping? No. The heart is being obstructed from doing its job. And so that is a form of obstructive shock. And so you would ask yourself, well, Hunter, what's the treatment for this? Well, a physician will go through the chest and stick a needle into this sac and hopefully drain out this fluid. That's called pericardiocentesis. Okay, pericardiocentesis. And the thing is, if you go too far and your needle starts vibrating, right? Right? So you go in and it's like, oh, it's vibrating. You puncture the heart. So you need to pull your needle back. And so this is the treatment. Now, how does this present? It's Beck's triad. And so that's going to be muffled heart sounds, uh, widening pulse pressure. So it's going to be muffled heart sounds. So again, sounding like they're breathing underwater. I'm not going to say this wrong and re-record this video, so let me make sure I say this right. Pause. Take a smoke break. Yeah, it's muffled heart sounds, ascension of JVD, and low blood pressure. That's what I thought, but I wanted to make sure. So it's called Beck's triad. So muffled heart sounds, a decreased blood pressure, and increased JVD. And so how this works is, again, as the heart can't accept the blood that's coming in from the venous side. It can't accept it because it's being squeezed on. Blood will back up here into the patient's neck, right? These are the external jugulars here. And so they will become engorged and they become big. And that's called jugular venous distension. And so that is Beck's triad. So now I'll give you a hint. The only time in EMT school you're going to see the word muffled heart sound is pericardial tamponade or cardiac tamponade. It is the only time you will hear that. So if you're reading a vignette and you see muffled heart sounds, boom, you need to be thinking, this is probably Beck's triad, this is probably cardiac tamponade until I can prove otherwise. So it's the only time you're going to hear that word. Now, if you read further in the vignette, they're probably going to tell you they have jugular venous distension, shortness of breath, increased heart rate, decreased blood pressure, right? And so those are, that's Beck's triad. Do know Mr. Beck, right? Beck's triad is from cardiac tamponade. Increased JVD, decreased blood pressure, muffled heart sounds. That's the triangle. So increase JVD, muffled heart sounds, and decreased blood pressure. And that's Beck's. Okay? So the treatment on this is, of course, they're going to have ultramental status because they have shock. But the treatment for this is we'll support their ventilations and transport them rapidly. Now, that's cardiac tamponade. Do know that. Now, moving forward to rib fractures. Again, I said these are fairly common, especially in old people. The ribs become more brittle. People like babies and children, they have very soft, malleable ribs. Okay, so they don't break them as common, but old people break them very common. And so it's very, very painful. And so a fracture of one of the upper ribs, four ribs, is a sign of substantial MOI. And so what? These ribs are fairly well protected by the collarbone and the shoulder girdles. And so if you get one of these broke, it took a lot of energy to do that. Okay, that's what they're saying. Now down here, it doesn't take a whole lot of energy, especially the floating ribs, to break those. And so, of course, as we've alluded to, a fracture rib may cause a pneumothorax, hemothorax, or a combination of the two, a combo mill of a hemopneumothorax. And so the rib fracture, again, it's going to be localized pain to that region. And so remember, with any broken bone, we tell patients, I want you to point with one finger and one finger only exactly where it hurts. And they will point exactly where the fracture is. It is like an x-ray. So it's very, very reliable. Localized tenderness and pain when breathing, rapid shallow respirations, patient holding the affected portion of the rib cage. Okay, let me explain this. So here's the patient's sternum, right? And coming off of each of these, this is a rib, right? So imagine these are ribs coming off the breath, not drawn to scale. But between here is muscles, right? The intercostals means it's between each costal. What the ribs, other name for ribs are costals. And so what happens is when someone breaks a rib, they will what's called self-splinting, to where these muscles will get tight and try to hold that area into an area of comfort. That's called self-splinting. Now, after a period of time, patients lose that ability, but that's an important thing to know. And so sometimes what they'll do too is they will hold that area to help splint it with their hands as well. That's another form of splinting that the patient will do. And so pre-hospital treatment includes supplemental oxygen. Now, if they're not breathing enough, you may have to support their ventilation. So watch out in a vignette. They're like, patient's breathing very shallow and 8 times a minute because it hurts, right? They're not breathing enough. You need to ventilate them with a BVM. Now, I'll call him out in this video. The EMS director of our agency, y'all have met him in class. I'm not going to say his name. The director of all of it. He was on a ladder once, and he fell off a ladder. He put a ladder on a table, and the table flipped, and he fell off, and he broke several ribs. Okay, and at first he went to the hospital. He has a very funny story that maybe he'll share in class one day. It's not funny. It was bad, but he tells funny stories. The way he tells his stories are funny. And so he went to the hospital, and they shot an X-ray of his chest, and they said, "There's nothing wrong, right? We'll give you some ibuprofen, go home." And so he went home, and a few days later, he's like, "Oh my God, I can't breathe. I can't sleep. This is terrible." So he went back, and they shot another X-ray, and they're like, "Oh my God, you have a flail segment. You have a flail chest." And so he had broken 2 or more ribs in 2 or more places, and so that's called a flail chest. And so this is the definition here. When 2 or more adjacent ribs are fractured in 2 or more places, that's called a flail chest. And so this is where you get the whole paradoxical movement. And so as the patient breathes, this section is going to move in an opposite direction of the chest, this particular area. And so the reason they didn't catch this on the first X-ray is because this guy was self-splinting so well with his intercostals, his muscles had actually pulled the ribs back to where they're supposed to be, to where when they shot the X-ray, they couldn't see the lines. So that's fairly common with rib fractures. You don't always catch them on the first X-ray. And so this is incredibly painful, and this can cause pneumonia because the patient's not taking deep breaths. It can cause dyspnea. I mean, in extreme pain. And so this movement that's described is called paradoxical movement, and this is when the detached portion moves opposite of what's normal. Okay, and so you'll see this little area will move in an opposite direction. Now, you'll see this on exams. This doesn't happen in real life because of splinting, because of intercostal splinting. So if this happened just now, right, more than likely you won't see this paradoxical movement unless it's a really big flail chest where you broke a lot of ribs. Okay, but usually 2 ribs, you won't see this. But it can cause paradoxical movement of the chest when the patient breathes. And so you're seeing this here. Let me zoom in. You're seeing that the patient broke ribs here, 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 even here. I guess they broke 3. And so that is called a flail chest. And so the chest will move in opposite directions. And you would ask yourself, well, most rib fractures we just allow to heal with time. No surgery, no nothing. You suck it up, buttercup. With time, it'll get better. Very painful. Encourage the patient to take deep breaths, and that's the treatment. And so what happens in a flail chest is you can't do that sometimes when they're large, and you have to go in there and add hardware and bolt them into place, basically. And so what the treatment for a flail chest is maintain the airway, provide respiratory support if needed. Again, if they tell you the patient's breathing 8 times a minute and shallow, or even 8 times a minute with a flail chest, you need to ventilate them. Give supplemental oxygen, and perform ongoing reassessments. Now, do you think someone with a flail chest is likely to develop a pneumothorax, hemothorax, or hemopneumothorax? Yes, it is quite possible. So this is why we reassess these patients. Okay. Now, again, treatment can involve a positive pressure ventilation with a bag valve mask, PPV with a BVM, right? And so that is sometimes the treatment. Now, I'm only saying it because they said it, but back in the day, we used to restrict this area with a sandbag. And in fact, the first ambulance I ever worked on carried a sandbag still for this. And so it was a sandbag that you would place over this affected area to prevent that piece from sticking out in the paradoxical movement. You would just say, hey, I'm not going to let that piece move because I'm going to put something heavy on top of it. Well, imagine putting something heavy on someone's broken ribs. That doesn't go well. And again, a flail chest is astronomically rare in EMS. You might see this in an ICU or a few days after the fact, but you probably won't see this in EMS unless it's a very big flail chest. Lots of broken ribs. because of the intercostal splinting. Those muscles in between the ribs will get tight and they'll splint it. Okay, and only after those muscles get worn out and they can no longer stay tight is when you'll see that flow chest. Now, pulmonary contusion is what it sounds like, right? So anytime you have a broken rib or a flail chest, you should suspect a pulmonary contusion. The pulmonary alveoli can become filled with blood, and this will lead to hypoxia. And so this bruise on the lung, this blood on the lung can lead to hypoxia, especially if they get rather large. And they can get rather large, because what is a hematoma? What is a contusion? It's a ruptured blood vessel. And so there's a lot of blood supply going to the lung, so these can get rather large rather quickly. Okay. The pre-hospital treatment is going to be supplemental oxygen and positive pressure ventilations as needed. Sternal fractures. This is the breastbone. We break this all the time in cardiac arrest, or we break the ribs attached to the sternum more so. So you have a risk of puncturing something, but that certainly can happen. The clavicle fracture is one of the most commonly fractured bones in the body. The clavicle is your collarbones right up here. It's usually from a fall on an outstretched hand. And so the patient will usually self-splint it and hold it close to their body. And possible damage to the neurovascular bundle is possible. Suspect the upper rib fractures and the medial clavicular fracture. So if you break the middle of the clavicle, you would suspect that you could break the ribs below that. Be alert to a pneumothorax development too. So think about this. The lungs run all the way up here to the apex, the top of the lung runs all the way up here underneath your collarbone. And so if you break that collarbone, especially the middle portion of it, you could potentially poke a hole in the lung and cause a pneumothorax. Now, this is called traumatic asphyxiation or traumatic asphyxia. And so the common example of this is someone is standing between like a vehicle and a wall, and the vehicle rolls forward and it squeezes them. And so what happens is, well, imagine a car was pushing on this female, male, I don't know, pushing on them. And so this is called asphyxiation. And so what you'll see is all the blood gets stuck up here into the head. And so this caused all the blood to leak out of the capillaries and exsanguinate, like to bruise essentially. And so you'll see bruising from the pressure point up. And so this is called traumatic asphyxiation. This is obviously very bad when this happens. This can happen usually from like a compression, like vehicles are the classic examples. Okay. You could also see this like partial ejection where someone's like halfway out the vehicle and the vehicle rolls and it rolls on top of them and it rests on top of them. You could see it that way as well. And so what is characterized as, again, all this blood is getting trapped up here because you're pushing down here. This is all blocked off. So the highway is going to back up, and so you're going to see distension of the neck veins, cyanosis. What cyanosis? It's this. It's bluish tint of the skin, and hemorrhage in the sclera of the eye. What's the sclera? We covered this in the recent chapter. I think it was last chapter. It is the white of the eye. So you'll get bloodshot eyes, basically. You'll get bleeding into the whites of the eyes because there's so much pressure building up here. It'll start bleeding in the eyes, and you'll be able to see it easily in the contrast of the white sclera. So that's traumatic asphyxiation. So this would suggest an underlying injury to the heart and possibly a pulmonary contusion, and a billion other issues like the abdomen and the pelvis, right? This is obviously very fatal when someone gets squished between a vehicle and something hard. And so ventilatory support and immediate transport is going to be the treatment. Now, blunt myocardial injury, again, you can bruise the muscle of the heart, and it's fairly easy to do this because it's just like if I were to frog you in the shoulder, right, in the arm, and it bruises, the same thing could happen to the heart. But it's going to happen in a more exaggerated fashion because your heart has more blood supply than your deltoid when you get frogged in the deltoid, your muscle here in your shoulder. And so this is the issue with this. It's rich in blood supply. So this can lead to a myocardial contusion. And also, just like when you get frogged in your arm and you really don't want to move it, right? Those muscles get irritated. The same thing can happen to the heart. It's not going to that area of muscle is not going to work optimally. And so you'll end up with increased or cardiac rhythm, cardiac issues. How this will present commonly is a regular pulse rate. And so basically, instead of the heart going boom, 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 it's pissed off. It's very angry. So it's like boom, 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 boom. And so it's very irritated. So those are called ectopic beats. And so you'll feel an irregular pulse rate. Okay. And so suspect in all cases of severe blunt trauma, injury trauma to the chest. Okay. Monitor the patient, transport him to the hospital. Now, what's that guy's name? He was the football player. It's the one that got hit in the chest and died on the field. I think it's something Hamlin. I don't do sports. Can't remember his name. I think it was like Dwayne Hamlin or something like that. Something Hamlin. And there's a condition called comito cordis. Sounds sophisticated. So this is what's happened to him. And so what happens is the patient will get a direct blow, very sudden direct blow to the chest. And it happens at this very critical point of the heartbeat called the absolute refractory period that causes the heart to be like, I'm done. And so you do not need to know that this rhythm, and so basically from here to here, it's called the absolute refractory period. And so if you get hit with a softball, or you get hit with a football player's helmet, or you take a steering wheel to the chest in a car wreck or something like that, at this precise moment in time between here and here, your heart can take enough energy, right, to go in loco mode, for loco, right? It's just going to start shaking like this. It's going to go into what's called ventricular fibrillation. And this is one of the rhythms that we treat with an AED. And so this is why Dwayne Hamlin had such a good outcome, is because they immediately started CPR and defibrillated him. And so he lived to tell the story. And so the rhythm is ventricular fibrillation. And ventricular fibrillation is when instead of the heart going beat, beat, it just shakes. It's literally shaking like this. And so this is not effective pumping. You will not feel a pulse. They will be in cardiac arrest. And so how you treat this is with electricity in the form of defibrillation. So you send a huge chunk of electricity across the heart, and it should shock it back into place to where it'll beat normally. Okay? And so that is what comito cordis is. The classical vignette before the Hamlin guy, the football player, was like a kid's playing softball or baseball, and they hit the ball, and it hits them in the chest, and they immediately go into cardiac arrest. And so this condition is called comito cordis, and you would treat it with early defibrillation and CPR. And so you may remember back in the movies, or like that people would like go up and immediately just bang on the chest and then start CPR, right? We don't do that anymore. But the idea was we defibrillate at like 100 to 200 joules. But that precordial thump, that bang on the chest, is around 5 joules. And so sometimes people think that will be enough to kick the heart back on. You know, I don't know. I'm not doing it, but I'm just saying that's why you see that in the movies. So laceration of the great vessels. Obviously, this will lead to very rapid fatal hemorrhage. If you break one of the big water hoses in your heart or in your body, you're going to leak a lot of blood really quickly. So you will die very, very quickly. Okay? And so pre-hospital treatment is going to be CPR, ventilatory support, immediate transport, be alert for shock. They're going to go into shock within minutes. Like within a minute, they're going to die, right? So they're going to go into immediate shock. Monitor for changes in baseline vital signs. Now, let me talk about this real quick. Let me draw it. So here's the heart, right? The aorta comes off. You have all these branches. And so this is the aorta. Well, there is a ligament that runs across here at the isthmus of the aorta. And so in a rapid deceleration injury, so someone's beat-bopping along in their car and they rapidly decelerate, like they hit a brick wall. What's happening is this aorta will travel forward, but this ligament will not. And so it'll tear the aorta. And you can imagine if every beat of your left ventricle is leaking into your mediastinum, you're going to die immediately. And so watch for that in test questions where they say, what happened? What is this? The answer is aortic dissection. And so, or an aortic tear, traumatic aortic tear is what it's called. And so, or traumatic aortic rupture, a lot of ways you can call this. And so these are the patients to where they get in a car wreck, and, maybe their wife or someone's with them, and Like, hey, are you okay? And like, I think I'm okay. And then they're unresponsive, and a minute later they're dead. It happens that quickly. And so I've ran car wrecks with this to where I suspect this has happened, to where bystanders got there, the patient had their eyes open, looking around, they're going into shock. Within a minute, they're unresponsive. Within 30 seconds more, they're in cardiac arrest. So this is fatal. This is very fatal when this happens. So watch for that. Rapid deceleration injuries. And so when the chest impact, so news, we're doing something new on these. I'm going to give it a shot. Um, these PowerPoints, these new ones I'm using, come with questions at the end. So we'll try to do some high yield questions. So that's the lecture. If you want to stick around for the questions, I highly recommend it if you're in my class, because these could show up on an exam near you. And so when the chest impacts the steering wheel during a motor vehicle crash with rapid deceleration, oh my gosh, Hunter just said that word, and resulting injury that kills almost 1/3 of patient, usually within seconds, is aortic shearing. Okay, that's what I just described to you. Okay, they will die very quickly. And I've ran calls where like the husband was like, she was talking to me for like, she said she was hurt, and then she very quickly went unresponsive. It's because she tore aorta. She was dying and didn't know it yet. Unfortunately, very sad. Okay. All right. Oh, by the way, you can pause this and screenshot it, do whatever you want to do to learn from it. But I'm not going to read all this to you unless I feel like it's necessary. You can also just hit the space bar and it's going to pause me, and you can read it, and I'll shut up and then hit pause, play again, and we can go on. So a sign and symptom of a chest injury include all the following except hemoptysis, which is coughing up blood, hematemesis, which is vomiting blood, asymmetric chest movement, which is when the chest are not moving equally, increased pain with breathing. The correct answer is B, hematemesis. Vomiting blood is not a chest injury. Oh, I'll slow down so you can screenshot these if you want. Okay. During your assessment of a patient who was stabbed, you see an open wound to the left anterior chest. Where's the left anterior chest? Well, it's mirrored, but for me, it's here. Okay. Your most immediate action should be position the patient on the affected side, transport immediately, assess the patient for a tension pneumothorax, or cover the patient or cover the wound with an occlusive dressing. So we were told that they were stabbed. Okay, so that sounds like and they have an open wound. That sounds like a sucking chest wound. What do we do with sucking chest wounds? We cover them. What can you cover them with while you're grabbing your occlusive dressing? Your hand, your gloved hand. Okay, so you're going to cover the wound with an occlusive dressing. Okay, you can use your gloved hand in the meantime. When caring for a patient with signs of a pneumothorax, your most immediate concern should be uh, hypovolemia. This means low volume. Intrathoracic bleeding. We see both of these with uh, uh, hemothorax, not a pneumothorax. Ventilatory inadequacy. We do have to worry about that. Remember, it's going to hurt to bleed, or associated myocardial injury. I think it's going to be C. I would agree with the book. Ventilatory inadequacy. So if they are ventilating inadequate, right? How do we fix that? We use positive pressure ventilations, and we ventilate with a bag valve mask. What purpose does a one-way flutter valve serve when used on a patient with an open pneumothorax? Okay, it prevents air escape from within the chest cavity. No, remember, a flutter valve is when you only tape it on three sides. So you have tape here, here, and here, but this allows air to escape from within down here. And so this would be wrong because it does allow air to escape. It allows the release of trapped air in the pleural space. That sounds good to me. It only prevents air from entering an open chest wound. I don't know about that. It allows air to freely move in and out of the chest cavity. This would be wrong as well. Yeah, it's what I chose was correct. Um, this is wrong. Let me show you why this is wrong. This you saw that, guys, in one time. I just got thrown off by this question. Let's talk about why this one's wrong. Okay, this is wrong because it doesn't only. So you got to watch for these exclusive words like only. It doesn't only prevent air from entering an open chest wound, but it also allows air to escape out. And so I hate questions like this. I like you just saw this, right? Like you're away from being a doctor, been a paramedic for 9 years, been teaching this for 5, and it threw me off. I didn't look at these questions beforehand. And so that's why you have to be careful with these exclusive words like only, okay? And so it threw me off in real time when they use exclusive words like that, okay? So you can take a picture of that if you want, or pause it. Signs of a there's 10 of these. Sign of a cardiac tamponade include all the following except, what's that guy's name? Named Mr. Beck? What's Beck's triad? Right? Muffled heart sounds, decreased blood pressure, and increased JVD. So let's look at that. Muffled heart, so everything except. So it does have muffled heart sounds. They will have a rapid weak pulse. They will have engorged jugular veins, not collapsed veins, okay? And narrowing of the pulse pressure is true as well. And so I'll explain this real quick because the slides didn't explain it, because you could see this on an exam. So pay attention. Narrowing pulse pressure is this, okay? So we know normal blood pressure is like 120/80, right? If I were to narrow the pressures between those, it could be written like this. Let's just do 120/110. That's a very narrow pulse pressure. So if you were to subtract these, that would have equaled 40. But if you subtract these, it equals 10. So what the narrowing of a pulse pressure means is the difference between the systolic, the top number, the diastolic, the bottom number, are very close. And so you see this in Beck's triad, because what's happening is the heart can't fully open up to decrease the diastole, and it also can't squeeze very hard for the systole. And so this is the issue you will see in Beck's triad, is a narrowing of the pulse pressure. So to confirm, in Beck's triad, you do see muffled heart tones. You do see a rapid weak pulse. You do see narrowing of the pulse pressures. A patient experiences severe compression to the chest wall when trapped between a vehicle and a brick wall. You suspect traumatic asphyxia due to the hemorrhage into the sclera of the eyes. And which other signs? They will have engorged neck veins. They will have cyanosis in the face and neck. They will have this is a sign, asymmetric chest wall movement, right? They would have equal. An irregular heart rate, you might see that, but that's not the dead giveaway. It's the cyanosis, okay? A 14-year-old baseball player was hit in the chest with a line drive. He is in cardiac arrest. Which of the following is the most likely explanation? We talked about this. Commito cordis, right? What rhythm are they normally in? Let's take this a step further. What rhythm are they normally in? They're in cardiac arrest. Ventricular fibrillation. And so remember the saying in the old country, the V-fib gets the D-fib. And so they get defibrillation. They get an AED, the clear, right? They get defibrillation. That's the treatment, along with CPR. Paradoxical chest movement is typically seen in patients with a flail chest. Remember, a flail chest, what's the definition of a flail chest? This is where you break two or more ribs and two or more adjoining ribs in two or more places. And so this is a flail chest, meaning that segment will move in the abnormal direction of everything else. A 40-year-old man who was the unrestrained driver of a car hit a tree at a high rate of speed, struck the steering wheel with his chest, and he has a large bruise over his sternum and a regular pulse rate of 120 beats per minute. You should be most concerned that he is, let's whip through these answer choices, has injured his myocardium. I'm going to say, yeah, that's certainly something I'm worried about. Okay. Has a collapsed lung and severe hypoxia. It doesn't say anything about the lungs, so I'm going to say, let's see. It has extensive bleeding into the pericardial sac. I don't see the signs of Beck's triad here, to where they say jugular venous distension or narrowing pulse pressures, increased heart rate. I don't see that, so no, I'm going to say no. But it is a possibility. Well, actually, I should have looked at these, right? Yeah, I had it right. Uh, yeah, but this is a possibility, but again, not great. Is it extremely high risk for ventricular fibrillation? Again, a possibility, but not entirely correct. What I would say is it's this one, is he's injured his myocardium. And so anytime there's a big bruise on the chest, the anterior portion of the chest externally, you can see a bruise. You would have to be worried about the internal bruise. And you'd be like, well, Hunter, how did you get to that answer? It's the irregular pulse rate. Remember, with myocardial contusion, the heart will be pissed off. It'll be irritated. So it's not going to beat as normal. Beat, beat, beat. It's going to be beat, 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 beat. Right? It's going to be irregular. Okay. And so how do you know that? You would feel their pulse and it's going to feel irregular. It's going to be, all right, it's irregular. And so that is the answer. Now, this is another really good question because it's tricky, and this is how they test y'all. These are all possibilities. And so I say it all the time, and hopefully these questions will at this late in the course, will show you. Uh, it's not the most right, or it's not always the only right answer. These are all technically right, but it's the most right, least wrong, right? And so these are all right, but this one is the most right. This one is the most right. So that's why it's correct. Now, there was a question back here that I want to come to. What's a ruptured diaphragm? What's a ruptured diaphragm? So the diaphragm is the muscle of breathing, okay? And so if I'm going to draw our human here, we know the diaphragm sits over here, and the liver sits over here on the patient's right, okay? And so what happens is if you take enough of abdominal trauma, you can force the abdominal contents into the diaphragm. The diaphragm's pretty thin, and you can rupture it, you can break it. And so when that happens, you end up with gut contents like the bowels and the colon and the stomach up in the chest. And so you'll hear bowel sounds up in the chest. And so if you're take your stethoscope and listen to your lower abdomen, those are bowel sounds. If you hear that up here in the chest, especially on the left side, you might after trauma, you might suspect a ruptured diaphragm. And so this never happens on the right side. Why does it not happen on the right side? Because the liver's on the right side. And so it's going to be impossible to push guts up all the way through the liver into the chest and the patient still be alive. That's just not going to happen. So these guts will take the path of least resistance, which is the left side, and will push into the chest cavity. And so that's it for this one. That was a long one. I kind of like the questions. I think those are helpful, so we'll keep doing those for the rest of the series. I appreciate y'all's time.